Hi, good morning everyone. Welcome to the Doctor on Call at the Parking Lot. I'm Dr. Gomez Nacer and I'm going to be bringing to you frequent scenarios and topics that are frequently tested at the United States medical licensing exam. Today I want to discuss neurology, and the first case is a patient that comes with difficulty seeing and tingling in the legs. It's a 45 years old female that is coming with this symptom and is coming for evaluation. Now, the question produces a lot of distraction, and at the end, we realize that besides the tingling in the leg, the difficulty vision, it has some increase in the tone and some Babinski in one of the legs. Now, with this element, the question is asking us what is the next step. Now, in the diagnosis, the next step can be an MRI, and the diagnosis we're thinking in this point is because our multiple lesions are lesions at the level of the second cranial nerve, to see the accommodation related to the movement of the eyes, the third cranial nerve. Another different lesion should be in other time, a lesion related to sensory into one side, and another part is a lesion related to the increase in the tone or the hyperreflexia in the other part. So multiple lesions at different points in time can be because of, for example, strokes, lacunar strokes. But also in this case we had to rule out the most common case. The first choice would be multiple sclerosis. Now, with this information, they can ask you what is the next step for the diagnosis, and usually we can say, well, MRI, or they can say what is the best treatment for controlling the disease in the acute phase of the optic neuritis or the optic symptoms. Usually would be the use of steroids. So this will be the right answer. Now, can we actually stop the sclerosis multiple? Is there any medication that we can use to stop the progression? And if they ask you, what is the best medication to stop the progression, then what would you use? Will you use steroids, or what will you use? Actually, the right answer will be interferon beta 1A or beta 1B. Also, there is a medication that is a combination of the amino acids that have been found in the myelin loss. So is lysine, tyrosine, alanine, and glutamic acid. So these are the four amino acids that are found in the myelin loss, and they identify this called an acetate glutaramic acid, something like that. This is basically medication conformed by this. It's like a polymer of this amino acid forming a small protein that seems to be helping to decrease the progression. So this is something else. Now, if they ask you what about a medication to decrease the rigidity, if the patient has rigidity, the symptom, and in this case what we use is the amantadine as like a general concept. And also they can usually for the tone, in the increase in the tone can produce muscle pain, because it's an increase in the tone. It's like the muscle is constantly working, is contracting. It's like a hypertonic palsy or spastic palsy, if you will, a symptom, because again this is not like a stroke, it's secondary to a degeneration of the central nervous system. But in this case, what will we do? We can use in this case dantrolene or baclofen. The dantrolene is acting at the level of the neuromuscular plate where the acetylcholine is deposited, and basically what it does is to decrease this release of the calcium from the endoplasmic reticulum. Now, the baclofen is believed to be acting at the level of the gamma-aminobutyric acid at the central nervous system. So these are general concept medications that are commonly presented as topics. So they can ask us what is the next step, what is the best, the most accurate, the most sensitive test for the diagnosis, what is the test for acute neuritis, what is the best medication for the neuritis, what is the best medication to stop the progress of the disease, is there medication to stop the progress of the disease, yes, the interferons, beta-1A, beta-1B, the glycemic acetate, which is the combination of this glutamic acid, lysine, arginine, lysine, arginine, and tyrosine. And if they ask you what is the best for the treatment of the muscle pain, dantrolene and baclofen, and they ask you what would be the best for rigidity, the amantadine. Now this is in general. Now another case can be, for example, a 22 years old man that comes with witnessed as a condition that the people that bring to this patient to the ER are describing as very weird movements. So the patient wakes up and actually you ask and the patient doesn't remember anything. But then you continue asking and eventually the patient mentions that 1 month ago he had involuntary movement in the arm, in the left upper arm. Now, that's mostly the information they give us. It seems to be something related to a tonic-clonic convulsion, and it can point toward a diagnosis of epilepsy. However, we continue in the investigation, and in the questions give us a keyword that the person has unprotected sex, and that he has paid for sex. So whenever they give you this information, the person who writes the question is trying to actually direct us toward some sexual transmitted disease, and particularly the extreme, the HIV or immunodeficiency syndrome. And basically we are talking about some opportunistic condition that can happen at the central nervous system, or some kind of disease that can be produced at the central nervous system that can justify, in this case, the person having involuntary movement in one arm, for example, or what the people witness as some weird movement that were actually, when we continue asking, tonic-clonic kind of contraction. So with this information, what would be our next step? Our next step would be to do a CT scan with and without contrast of the brain. And let's say they say, well, correct, the next step, we find the results and give us a result, and they describe it as ring enhancing lesions at the parietal left parietal lobe. Now with this description, what is the diagnosis? Ring enhancing usually is referred as either it can be either a toxoplasmosis. It's like a hole that it has circumscribed with increased radiopacity, right, or increased absorption of the contrast. So ring enhancing seems to be something. It can be either a toxoplasmosis or a lymphoma whenever we hear these words. Now, what is the next step? What will we do? Now, the treatment will be pyrimethamide and also sulfadiazine. If the person is allergic to sulfas, then we will substitute the sulfadiazine by clindamycin. And we will give this treatment for 2 to 4 weeks, and then we will repeat the CT scan. And when if the exam shows that is shrinkage, that is decrease in the lesion, we continue with the same treatment. If there is no decrease in the lesion, basically the treatment is doing nothing, and then we will have to go to the next step, which will be to actually conduct a biopsy to identify if there is a lymphoma. So basically this is in general some of the scenarios they put in that context. Now, another patient can be a 70 years old man, for example, that comes with a wife stating that he suddenly lost the breakfast, and the dishes went to the floor, and so basically he could not hold the dishes with his hand. That was a symptom. Now we immediately, and she believes that it is normal because of the age. Now we always were going to, when we hear that, with that chief complaint, the dishes fall from his hand. That's a chief complaint. Now we have to think: is this a vascular problem? Is this a stroke? Is this something that is producing weakness? What is this condition? Now, with this element, we actually conduct a physical exam, and we find that actually the patient has weakness in the left arm and in the left leg, and there is some. We are not having yet a result of a CT scan or MRI, but with this evidence, it points towards some sort of a stroke, something at the central nervous system, right? So then, what is the next step? Again, with the focalization, we do a CT scan, and in the CT scan, it can show us either, for example, a crescent, which is like a space that reminds the crescent of the moon, right? And there will be epidural hematoma, or in this case, they can show us some concentration, some more diffuse inside the brain that seems to be passing through the ventricles, and that will be a subdural hematoma. Okay, so basically, in the history give us the fact that this man, how come we have it like that? The only element that we found in the history was the patient had some sort of trauma produced for riding his horse frequently, and so in this age group, the people that rides the horse can have this kind of symptom. Okay, so I mean, even a small trauma represents a big trauma because of the age, the decrease in the ventricles, so it produces a really big trauma, and this is why it produced the hematoma in this case. Now, another case can be a patient that is, for example, presented, again, this is an elderly man also. Is coming because the wife is complaining that she is finding him some difficulty to walk. So I am having difficulty to walk, doc. So something like that is a chief complaint. And then we can be a lot of different sort of distractions in these questions. And it's in the 60s man. And then it described that the man started to write to his wife, and she cannot understand what he writes, and the letter is a little too shaky. Now she also complains that she finds him with some sort of tremor, resting tremor. Now when we see that resting tremor, we immediately think, like a key factor, that this is Parkinson, right? So what we have to do is to differentiate Parkinson's disease with some other conditions. We don't have a biopsy to identify Parkinson. Parkinson per se would be like decrease in the substantia nigra. It's an affection to the substantia nigra that produces the dopamine. So in this case, how can we diagnose it, and how we make the differential diagnosis? We can have Parkinson, for example, combined with difficulty in the vertical gaze. Whenever we have that, it's usually something called progressive supranuclear palsy. So it's something above the level of the substantia nigra. It's something that usually comes with palsy in the cerebral nerve, right? So right there, that will be at the level of the midbrain. So right there, this is something that also can produce some sort of tremor, but the tremor is not the resting tremor, it's intentional tremor, because it's something most likely associated with pontocerebellar syndrome, right? So it doesn't have that kind of tremor. The differentiation is between a resting tremor of the Parkinson By the way, Parkinson described this like in 1870, and this new description for portocerebellar syndrome and the supranuclear palsies are something relatively new. So it's like in the 70s, something like that. A group of 3 physicians that described that. Now, we can also have the Parkinson associated with ataxia, and that is also can have also intentional tremor. So the tremor is when the person is doing something. It doesn't match in this particular case. What would be the treatment in this case? Now, in order to go with the treatment, we will have to identify which one, if the person is functional. So we have to measure things like dressing, undressing, cooking this food, taking the shower, things like that. And with that information, we can decide if we go with the typical drugs or we don't have, what is the medication we use. Usually we can do the treatment in this case for the patient that is functional. We try to use, for example, for the rigidity, we still use the amantadine also. Because this is an antiviral medication. Almost by chance, the amantadine was found that it actually seems to be increasing the release, the metabolism, the reuptake of the dopamine at the central nervous system. So this is something that is promising. In many ways, people start using the amantadine. What is the risk? The risk is that the amantadine is associated with hallucination. So it's some sort of psychotic drug. We have to be careful with that in that sense. Now, selegiline is another of the drugs that can also be used. Apparently, it's also you have some sort of a hope because of the increasing also in the substantia nigra or dopamine production in some way. And also we used to use these medications that are used for cluster headaches, which are bronchoconstrictor, which are alkali drugs produced for, like, for example, bromocriptine. So these drugs produce vasoconstriction and in some way have been demonstrated to improve a little bit in this Parkinson that has a good function. So we have there the bromocriptine, the sumatriptan, and we have the pantoprazole or propranolol, something like that. So those are new medication that does not produce so much peripheral constriction, vasoconstriction. So, for example, they are probably better used in this case. So it's still a lot of caution because the bromocriptine and sumatriptan, this medication, because they are vasoconstrictor, we have to be careful with what? Myocardial infarction, coronary artery disease, peripheral vascular disease. So basically, anything that is vascular has to be in consideration at the time of using these drugs. And these are in general some of the cases I just wanted to share with you, and I think it can be helpful. And please come back to another Doctor on Call at the parking lot. Thank you very much.